So now we're going to talk about low oxygen. So PaO2 less than 60, SpO2 less than 90, on FiO2 greater than 60%. Along with this, your patient will be hyperventilating. So the ABG that you'll see would be something like this. On whatever, 100% non-rebreather for this example. So the patient is hyperventilating, so ventilation is not the issue here, oxygen is. So my patient is hyperventilating because they're trying to get more oxygen into their system. That make sense? This will turn into hypercapnic respiratory failure if you don't fix it. But we try not to let it get that far. So there will be patients that get intubated for oxygenation problems, even though their CO2 will be perfectly fine. So this is where you get to oxygen is important. Ventilation is primary if ventilation is the problem. So if your patient is not ventilating, you fix ventilation because you'll fix oxygenation. But this is where you will now learn that there are some times when ventilation is not the problem, and if your patient is ventilating just fine, you need to fix oxygen. Does that make sense to you guys? So oxygen is important. I know you hear many, many things about fixing ventilation, fix ventilation, fix ventilation. But there are some times when that's not the issue, and this is an oxygenation problem. So we'll talk about what leads to those. So the two that, I'm actually going to write this side by side so I don't lose all that space there. And from what we learned yesterday, you guys, what kind of AA gradient would that patient have right there? A really big one, right? Really high. Did you have to do all that math?
No.
No, because you knew it. What? Okay, so we're going to distinguish between VQ mismatch and shunt. There's going to be 3 under this one too. So A is VQ mismatch and B is a shunt, but these work well to do them side by side. Because it's never both, it's one or the other. So VQ mismatch is a FiO2 less than or equal to 60%. So these patients are on lower FiO2s. Shunt patients are on high FiO2s and usually high peaks. What is something that you think could lead to a VQ mismatch?
Poor perfusion.
What's that?
Poor perfusion.
Okay, what particularly, Mike, is related to perfusion? What would cause lack of perfusion to your lungs? Huh?
Edema.
No,
THF.
the edema does fall under here, but not for that reason. What would cause blood to not flow to the lungs? A blood clot, a pulmonary embolism.
Give us the answer, please.
But nobody was going where I wanted them to, so. So,
That was my next guess.
examples of things for VQ mismatch pulmonary embolism. Pneumonia, which we abbreviate PNA. Mild to moderate CHF. COPD. I'm not going to list that one under there. Asthma. Basically, what we see is in a VQ mismatch, it's more of an isolated problem. So let's say we have right lower lobe pneumonia, or you have a PE in the right upper lobe quadrant, or you've got mild CHF, so only part of the lung is affected. So there's a problem with ventilation and perfusion. They're not matching up. Either ventilation is not happening or perfusion is not happening. And for whatever reason, they're not matching up. But your entire lung is not affected. In shunt, it is. So in shunts, examples would be, the main ones we see are ARDS and severe CHF. And in these patients, the whole lung areas are affected, which is why they need those higher FiO2s and PEEPs, which we started to talk a little bit about yesterday. So your X-ray will match this too. Over here, you can have what we call the whiteout. Yeah, as I say, or sometimes we also call it ground glass appearance. Ground, like you took glass and you ground it into little fine pieces. This, your X-ray will just show problems in the affected area. So I've got consolidation in my right lower lobe, but the rest is fine. Everybody with me so far?
Yeah.
Okay. VQ mismatch patients respond to supplemental O2. These patients do not, as we see here. Patient on 100% and their PO2 is 58. We're giving them more oxygen, but it's not doing anything. So when someone doesn't respond to supplemental oxygen, it's called refractory hypoxemia. And I will show you. So let's say your PaO2 and your FiO2. So 50%, my PaO2 is 53. 60%. Now, if my patient has a VQ mismatch, if I increase to 60%, I see some kind of response. Maybe it goes to 83. In a shunt patient, what will happen is it won't really change. It might go to 54 or 55, but it's nothing significant. 56 on 70%, 56 on 80%, 57 on 90%, 58 on 100%. So that is refractory hypoxemia. So it's not responding. there's so much going on in the lungs, there's no way for the oxygen to get across and into the capillary. So the shunt patients are the ones with the really high AA gradients and the really low P to F ratios. So we could say P to F ratios, depending on where they're at, really anywhere less than 300. And the AA gradients greater than 350. And remember, all of this is on the high FiO2s. So on the FiO2s, I'm not talking about someone with a P to F less than 300 on 2 liters. It's the patients that are on the high FiO2s, and those come into play. So what happens is, the way you can visualize it, if this is, so this is 650 and this is 50, and our gradient is 600, it's because there is something going on here that's preventing the oxygen from diffusing across. And that's usually fluid, because ARDS has too much fluid and CHF has too much fluid, as you guys will learn. It's fluid for different reasons, but the problem is too much fluid. So I like to say that one of the analogies I use to help you with the AA gradient problems, and so if you have all that fluid, or even what will eventually turn into fibrosis and scar tissue, the oxygen can't diffuse across. And you have to remember, CO2 goes across a lot faster than oxygen, right? Kind of remember that? So oxygen has a much harder time diffusing. So if you think about a stream, it hasn't rained in a long time, the stream's just kind of still and quiet, and it's easy to walk across to the other side. So I'm here, I'm oxygen, and I need to get to the capillaries on the other side. And the stream is the interstitial space. So when everything's good, we haven't had a lot of rain, there's not a lot of debris and stuff in the water, we can just walk right across. That's our normal body, or even patients maybe with a BQ mismatch. They don't have all this mess in the way. Patients with a shunt, their interstitial space and the space in between in the alveoli themselves is a disaster. So think of a stream after we've had tons and tons of rain. It's moving really fast. There's branches in it, dirt, debris, rocks, and you can't get to the other side. That's what's happening in these patients with shunts, is your alveolar levels are a mess with inflammation and red blood cells and fluid, so that the oxygen can't diffuse through, which is why it's so hard to treat. And it's why PEEP is used, is to help try to stent them open.
So shunt's more like a compliance.
Oh, shunt is a huge compliance problem, absolutely. So you'll see these patients with horrible compliance. They're very, very hard to ventilate and oxygenate because their AC membrane is so rigid. And because if I have all that fluid, do you have surfactant? Nope. Yep, it washes it all out. So as we go forward, we'll talk about those patients more. But that's why it's so important to understand. And if your patient is on 70% and 10 a PEEP and their PO2 is 50s, you know they have a shunt. Because otherwise, they would be responding and you wouldn't need so much oxygen. Does that make sense? I mean, it's really easy to know the difference between these two if you just really look at what's happening. So the last one is a diffusion defect. And the other thing that's important to understand out of all of these, although they all fall under hypoxemic respiratory failure, these patients here are the ones that are getting intubated. This patient who has a PO2 of 58 on 100% non-rebreather needs to be intubated, because we've given them all this oxygen and it's still not doing anything. Does that make sense to you guys? So you see all this, you got the whiteout, all this other stuff going, they need to be intubated. So that's a patient who will get intubated for an oxygenation reason. Those patients need time for their lungs to heal, or they need a lot of Lasix, depending on what the problem is. And sometimes it is really just time, and all we're doing is supporting. Because remember, mechanical ventilation is not a cure for anyone. We're just supporting our patient's lungs. So a diffusion defect is our patients with emphysema and pulmonary fibrosis. These are patients who have permanent damage to their AC membrane. The shunt patient might not be permanent, so sometimes people want to know what's the difference, because these patients have a problem with diffusion too, but it's because of what's happening, and hopefully it can be fixed. These patients, it cannot be fixed. There's no cure for either disease, and pulmonary fibrosis is fatal. It's a terrible, terrible lung disease with horrible compliance and scar tissue that just forms more and more and more. AC membrane. So in emphysema, we see destruction of all the AC membrane because of all the damage from smoking. So instead of having all your billions of alveoli and all the surface area around each specific one, like a bunch of grapes, right? It turns into this. And that is not good surface area anymore, because instead of a whole bunch of little sacs, we now just have one big one. So we don't diffuse well because of that. In pulmonary fibrosis, just to give you, this is scar tissue. And they don't diffuse well because of that. And there's no cure for it. Yes?
What about cystic fibrosis?
Cystic fibrosis is a secretion problem in the lungs, and it's also more of a systemic problem. So even though it's called cystic fibrosis, it does not have the same fibrotic damage like pulmonary fibrosis does. It's very confusing. People always think that.
Yeah.
So cystic fibrosis is an obstructive lung disease. Pulmonary fibrosis is a restrictive.
And emphysema is restrictive too.
No, emphysema is obstructive. Obstructive, restrictive. Patients can't get air out, patients can't get air in. That's the difference between restrictive and obstructive in very simple terms. So pulmonary fibrosis can happen for a reason or not a reason, right? Some people just get it. So the only option for them is a lung transplant. So these patients don't get intubated for their lung disease because we can't cure it. So what effect does it do putting a patient on a vent? I'm not going to say that an emphysema patient never ends up on your vent. They could have CHF or pneumonia and go on the vent for that reason, but they're not going on because of emphysema. Pulmonary fibrosis patient, we don't put them on vents. It's a long-term terminal illness, and the patients would end up going hospice or getting a lung transplant, one of the two. So the best thing you can do for these patients is pulmonary rehab. O2 or lung transplants. Jeremy.
So the pulmonary fibrosis, if they're going to code,
What's that?
if they're going to code, we just bag them till.
No, you don't see many pulmonary fibrosis patients end up in the hospital and coding there because they die at home with hospice. And you really would not be able to bag that patient. I'm telling you that if you think about when you leave a sponge on the counter and you let it dry out. That's what you'd be trying to ventilate. It's impossible to bag that kind of patient because there's so much fibrotic lung damage. So all the AC membranes are now scar tissue. So the patients, what happens is they basically suffocate to death. It's a terrible, terrible disease. And they'll die from severe hypoxemia. Because at the end of life, a lot of these patients are on 15, 20 liters of oxygen. When you guys, is anybody in pulmonary rehab? Have you, any of you seen a pulmonary fibrosis patient?
Yeah, our favorite patient has pulmonary fibrosis. And
Yeah.
you can barely even see, like, makes me sad to think about him, but you can barely see him even breathe, take
Yeah.
the breath in and out. I mean, it just barely
My grandma was
moves.
Yeah.
Yeah.
Yeah, and then when they try to walk or exert themselves in any way, their O2 sats fall to the floor. It's unlike anything. I mean, they'll go into the 70s, and a lot of them, their normal O2 sats are in the high 80s. Like they can't get them higher than that because the oxygen just won't diffuse, and it's very hard for them to even get any air in. If you took a surgical band that they put around patients that they have surgery and put it around your chest and try to breathe and walk. Maybe that's what we'll do one day. You can see what it's like to have a restrictive lung disease.
Get some space.
So what?
Do it every day anyways.
Oh, yeah.
A waist
All right. Do you guys have questions?
So we're not.